It's our CPD with Charmaine Mensa, senior physio. She's so qualified. Qualifications are qualifications. Today we're going to be speaking about pelvic health and Cauda equina syndrome and red flags. Is that right, Mensa?
That's correct. Okay. So welcome everybody. Thank you for coming today. So I thought it'd be good to talk about particularly mixed urinary incontinence and Cauda equina and differentiating the difference between the two, because a lot of the time we ask these red flag questions and a lot of patients will say, yes, I leak. And then you're like, okay, is this Cauda equina or is this something else? So urinary incontinence. What is urinary incontinence? What's your understanding of urinary incontinence? Yeah? Yeah. So, yep. Exactly. One. Elliot.
Lack of control.
Yep. And then what?
Emergency or...
Exactly. Yes. And there's two types: mixed urinary incontinence. Mixed urinary incontinence is a combination of stress incontinence and urgent incontinence. Very, very common in women and in men. More common in women than men, and it's generally a non-emergency condition. Whereas Cauda equina, obviously, is a neurological condition that affects the spinal cord, the cord, and is important to be diagnosed urgently because delay in treatment can be detrimental to someone's quality of life. So it's really important in our role to be able to differentiate the two. So I've spoken about what is mixed urinary incontinence. So a lot of women at menopausal age, which is 50-51 in the UK, will experience potentially some form of incontinence. Do we know why? Postmenopausal women are more likely to...
lack of strength. Is it also cause change the structure of the pelvis?
Yes, more to do with hormones, which I'll come more into. Yeah, exactly. So the drop in estrogen initially, and then that depletion of estrogen affects your connective tissue. So pelvic floor is connective tissue. Like I said before, mixed urinary incontinence is not life-threatening, but it can be quality of life debilitating. You know. So cause of mixed urinary incontinence. So it's about weak pelvic floor. Anything else you can think of? Hormonal change you mentioned.
Isn't sarcopenia more common as well?
Yeah.
So you'd be more likely to experience atrophy.
Yeah. So just general aging changes. UTIs, for example, irritants. So irritants such as caffeine, alcohol, neurological factors can also cause incontinence. Can you think of any neurological conditions that might cause incontinence? Yeah. The MS, FND, Parkinson, functional neurological disorders, yeah. And yep, exactly. So there are neurological conditions that can cause incontinence. Think about patients that are on wards, for example, or patients that we may see with dementia, Alzheimer's. They might forget to go to the toilet and they might then get overflow, or they might get, for example, weakness, pelvic floor muscles because of their age, and then they forget and they go incontinent. So there's a lot of contributing factors for mixed urinary incontinence. Now, going on to Cauda equina, what is Cauda equina? So if a patient comes into you, how would you explain what Cauda equina is to a patient?
A compromise to the peripheral nerves that go to the bowel bladder. So which would cause like an upregulation, downregulation.
Yep. Anything else? Anything else?
Well, in terms of the symptoms.
Yeah. What else is Cauda equina?
Most like urinary retention that can cause dripping, UTIs, inadequate emptying, defecation, bilateral neurological symptoms, and then you've got Cauda equina syndrome incomplete as well, where you could have like a less strict form of symptoms.
Yeah, yes, absolutely. So it's a serious sudden onset of compromise to the spinal cord in the lumbar spine that supplies the pelvic organs.
So it can be central as well. It can be
Yeah. Yeah. So if you think about the peripheral and sensory nerves, if there's a cord compression, it affects all those nerves, all those nerve fibres. You can have caudal equina compression and not actually have any symptoms as well. So many patients may go for an MRI scan and it shows they've got caudal equina, but they're non-symptomatic. So they don't necessarily always need medical intervention unless they're symptomatic. And that's generally when you'll see them. They don't come into you with no symptoms, usually have back pain, leg pain. So red flags, a red flag, obviously when we're screening patients, we're always asking red flag questions for caudal equina. A red flag is a serious, obviously, compression of the spinal cord or a serious condition that can affect a patient. Does that make sense? Yeah. So red flags are signs and symptoms that raise suspicion of serious pathology. Yeah, so we're talking about caudal equina, we're talking about that. So you mentioned already earlier about some of the symptoms of caudal equina. So bilateral leg symptoms. It may start off with unilateral and it may then develop into bilateral. Yeah, so you may ask the patient when you're doing your subjective assessment if they say they have bilateral symptoms. When did the unilateral symptoms start? Has it developed into bilateral? Sometimes they may have unilateral, then it's bilateral, then it's unilateral. So that's still important to know. Muscle weakness. So generally with delayed onset of caudal equina, you won't always get muscle weakness initially. Can you think of a typical motor weakness you might see in a patient with caudal equina? Yeah. So that could be an early indication of weakness. Or what subjective symptoms may they say with weakness?
Would they say their legs feel heavy?
Yeah, exactly. What else could that be though?
Could just be actual weakness.
Yeah, or it could be a vascular issue, for example.
Oh, okay,
yeah, it could be something else. And that's why we've got to ask lots of questions. So our subjective assessment is a lot more detailed than your objective assessment because you're knowing from your subjective what the diagnosis is. You're just ruling out serious pathologies. So we'll ask about, I don't know if you ask about pain, night pain. Do you ask? Yeah? Yeah, why'd you ask?
Well, for me, it's because of the correlation to like carbon science as well, so the correlation to cancer.
Yeah.
Like especially brain lesions and like that.
Mm-hmm. Yeah, and it's usually the second half of the night you're asking for their symptoms.
There's a certain C word.
Yeah, but it's usually you ask. And sometimes with sleep. So when you say generally disturbed sleep, is it positional or is it actually the waking up because of the pain? There's a lot of patients say, I can't get sleep. Okay, it's more like it's positional rather than actually a serious red flag. And then saddle anesthesia is another symptom which we'll come on to. So other red flags of the spine, past medical history of cancer. So if someone has a past medical history of cancer, obviously you want to ask what type of cancer it is. Cervical, you're definitely going to be thinking they need to be sent for some urgent scanning by the GP. Because you're thinking either testicular cancer or cervical cancer. Lung cancer, for example, they may have lung cancer, could be shoulder symptoms, Yep. Absolutely. So any history of cancer basically will raise your suspicion for serious spinal cord pathology or even cancer again. Age is another red flag. So the elderly population more likely to have some canal stenosis because of natural aging changes. So stenosis is narrowing of the spinal canal because of arthritis. Use of steroids or intravenous drugs again increase that risk of infection. Steroids thins the bones, affects the bone quality. So if someone's been on prolonged steroids, so you again should be asking that question in your subjective. Have you been on steroids? Yes. How long for? A lot of people say inhalers. That's different to being on prednisolone, for example, for a long period of time. Usually people that are on steroids, even if it's a cancer treatment, again, that might raise your suspicion. They might have forgotten they've had cancer, but they've been on steroids. And, it opens up those kind of questions for you.
How long is it on steroids?
Good question. So I think with prolonged use of steroids, it's usually over more than 6 months because that's what's going to affect the actual quality of the bones. Saying that, if they've been on steroids in the past and haven't had been on steroids for years and years, less likely. Patients that are on steroids for a prolonged time usually will have DEXA scans to check their bone quality. So if they're on a prolonged course of steroids for, I don't know, COPD, for example, or they have, steroids as a kind of emergency kind of pack, usually those patients should be kind of reviewed every 3 to 5 years. And you might even ask the patient, "Are you doing a DEXA scan?" Or they might say they've had a DEXA scan. They're like, "Oh, why have you had a DEXA scan for? Have you had steroids in the past?"
What about just steroid cream?
Yeah, topical, doesn't
Doesn't affect like actual steroids, like
it's more about intravenous into the bloodstream.
Is there a certain level as well?
I don't know. I'm not sure. It's usually a prolonged course of steroids, and usually, so if it's like a topical steroid, that's unlikely to affect the bone quality. It's more the skin tissue, so they might have more frail skin. They might break easy. Whereas someone that's on an oral steroid that goes to the bloodstream will actually affect the bones. But dose-wise, it's usually over a prolonged course of time. Some patients, when they have a high dose of steroids because they've had a recurring chest infection, that's not going to cause osteoporosis. That's not going to cause a broken bone. Because they're on it for usually for bouts of times, 6 months, and then it's usually kind of weaned down, so it starts high and comes down. Okay. So with past medical history of cancer, so one of the questions again you may ask with cancer is about weight loss. Do you know how much weight loss is significant for cancer? So the research kind of indicates 5% of body weight, total body weight in 6 months. So you say to patients, if you lost any weight unintentionally, you want to ask how much body weight they've lost. Because again, that's another red flag. Why are you losing weight unintentionally? And how much is too much weight loss? Yeah. And again, this is beyond our scope. So if they're saying yes to these, you're referring back to the GP. Okay. So going through the Cauda red flags, just breaking it down a little bit more. So we spoke about unilateral or bilateral leg pain. So we spoke about other factors potentially that could cause or mimic unilateral leg pain, so vascular issues. So you'll know that from your subjective questioning, their past medical history. The smoker, again, increase the risk of vascular issues. And when you're asking about unilateral leg pain, any other questions you think you might ask in relation to that? There's someone reports they have leg pain. What more do you want to find out?
If it's on exertion, so if it's walking uphill, if it's walking for a long period of time.
So what's that?
In positional.
Okay, so what are you thinking when you're asking that question?
So I'm trying to deviate whether it's, for example, vascular stenosis or canal stenosis. So canal stenosis, they might feel it walking downstairs, walking downhill. They might find that they lean over their shopping trolley when shopping for relief. Whereas with, and they might find more immediate relief on sitting. Whereas with someone with vascular, it will take a little bit longer to recover, and it's more like uphill on vascular exertion.
Yep. Anything else?
Oh, colour or heat?
Yeah.
Infection. If they're getting more infections, or if they're getting like skin blisters, sores, things like that. Toenail infections, things like that.
Yeah. So and diabetes is a big thing, isn't it?
Yeah, with hair loss as well can be a sign.
Yeah, sign of.
Hair loss can be a sign of reduced vascularization.
Yep. Anything else? No. So these are kind of questions you can ask. So again, differentiating: is it a vascular issue with leg pain? Is it like a compartment syndrome? With exertion, for example. Someone has bilateral symptoms, straight away you should be thinking, is it the spine? Yeah, unilateral symptoms, it could be just sciatica. If someone says they have bilateral buttock pain, bilateral leg pain, straight away you're thinking, is there some kind of spinal central cord compression? Because with a peripheral nerve, if it's sciatica, it will literally be one side. If there's a massive disc bulge or stenosis of some sort because of arthritis or disc or cyst or whatever it may be, it will affect the spinal cord, which will then give you bilateral symptoms. Yeah, so straight away, you want to kind of in your head be thinking, is this a central component involved? How far down down the leg does it go? So with sciatica, you can get that typical kind of radiation in the back of the leg into the foot. Whereas if they say it's just in my calf, you're less likely thinking it's a sciatica. Is it a vascular? Is it a compartment? Again, which is beyond our scope. You're going to write to the GP or send to A&E. Okay, so I mentioned about saddle anaesthesia. So, do any of you do your dermatomes for saddle?
Well, I don't actually test them.
Okay, how's that? Yeah, you can do it in the groin.
Oh yeah, but even then I feel like if I was asking questions, is it done with your wife or do yourself in your wife?
Yeah.
I feel like people would expect me to do that probably.
Yeah. No, yeah. I think as a male patient, it's always a bit more.
I'm not a pelvic health specialist. You say you're a pelvic health specialist, are you used to that area?
Yeah. No, yeah. No, of course, no. Yeah, but yeah, exactly. You're really relying on your descriptive skills, aren't you, to ask patients, do you have any numbness when you wipe? Any other questions you might kind of ask, or how would you prompt for that? Because it can be a bit awkward, I think, sometimes. Yeah. Okay. Yeah. Anything else? Yeah, for men, what for women? So for women, you say about wiping. For saddle anaesthesia? No, yeah. So with saddle anaesthesia, so numbness in the saddle or changing function or changing sensation of the bladder. So, for example, wiping, changing sexual activity. They've got they can't feel. Can you feel it when you have intercourse? Does it feel different because it's affecting those internal organs as well, or the internal nerves as well. So they're the kind of questions to ask. Ejaculation issues. And again, these questions you ask may then think, oh, actually, maybe it's less of a Cauda equina, it's more of a pelvic health issue. They might say they have ED, erectile dysfunction, but they're 70-year-old. There's an enlarged prostate, which goes to the toilet a lot at night time, which isn't a Cauda equina issue. It's more of a. But again, both can exist at the same time as well. So someone can have these pre-existing symptoms of pelvic health issues and come in with Cauda equina, and that's when it's difficult to differentiate.
Do you give background, like when you ask those questions, would you describe to them about Cauda equina before asking those like very specific questions?
Yeah, so when a patient comes in with any back pain patient asks them all the red flags for the spine. So I'll say to them, when it comes to saddle anaesthesia, I'll give them the examples, because if you say any saddle anaesthesia, no one knows what that is, or any numbness. So I say, do you have any change in sensation when you wipe, when you go to the toilet? Can you feel when your bladder's full? Do you know when you're emptying? When you wipe, can you feel the tissue? When you have intercourse, does it feel the same? Does it change? Just explicitly ask those questions. Because at the end of the day, you're the professional. If you feel uncomfortable asking those questions, you've been missing something quite serious. Yeah. And again, sometimes it could be actually that it is nothing to do with the spine. It is just a pelvic health issue. Yeah. So it's really important that we ask about saddle anaesthesia. It can also differentiate is there a perennial nerve injury. So someone might gone on a bike and pulled down and hit themselves and have a saddle injury, and that could be actually a pudendal perennial nerve problem. Yeah, or kickboxing or BJJ. Might be kicked in the nuts and then they have that altered testicular pain, and testicular pain could be a red flag for cancer. So really important that we kind of work out and always differentiating. Is it a musculoskeletal issue that we can refer on to A&E or GP, or is it something else that maybe I could see in pelvic health, for example? So I spoke about questions as well. Anything else that can potentially cause saddle anaesthesia? Anything out of the box? I think could change the sensation in the saddle. Yeah. So if someone's had an episiotomy, which is a cut to help with delivering baby. If they've had prolonged labour again puts a lot of stress on the pelvic floor. If they've had to have a catheter in situ, for example, then the bladder may be affected because of that. Medications can affect your libido. Antidepressants, people on antidepressants these days, their libidos that changes their sexual function. So asking those questions, and also asking how long you've been on those medications, because you could say to them, let's go back to your GP, if this is affecting you, ask your GP to maybe review your medication to see if that improves this.
So the differentiation would be arousal rather than sensation. They said they might say,
Yeah.
I feel it, but I just don't come around, versus I
Yeah.
don't feel it.
Yeah, good question. So I think sometimes it's also it's the function. Yeah,
Oh, okay, fine.
it's a
Okay,
function.
okay.
So being able to get an erection, but again, it's still your nerves that's affected. So it's more about when did this start? How long has it been ongoing? If it's been going on for a long time, as in more than 2 weeks, then I wouldn't be concerned. I've got a patient who's had reduced sexual function 15 years. I'm not going to change that. Been on antidepressants for a very long time and lots of yellow flags. So I'm not concerned, and it hasn't changed. Yeah, it's not changed in the last 15 years. Yeah. So Katie said about interventions during childbirth, asking how long it's been present for, where did the sensation start? So some people will say they've got all the sensation, but it's actually in their groin, not in their vagina, not in their penis, not in their testicles, in the genitals, basically. It might be all the sensation in the groin. They might say tingles here. Yeah. So again, to be as descriptive as possible. So you mentioned about ejaculation and erections. Again, just ask more questions about that and being confident to ask those questions. They are always difficult questions to ask, but it can help to differentiate and also help with when you're writing your letter to the GP or signposting them to A&E. So we're looking at the S2, S4 nerves, which is the nerves that are important for sexual function, bladder and bowel function. Obviously, you may be comfortable checking that, but it literally is just on the outside of the labia and around the back passage. Okay. So going back to the sensation symptoms. So a lot of patients, you may find there is some yellow flags with their symptoms. So with sexual function, can you think of any yellow flags for sexual function? Yeah, exactly. Sexual trauma, and that can change their sensation. It could be more of their association, actual physical sensation. Okay, urinary function. So if you think about frequency of the bladder, so when you're asking these questions, so a patient may say, okay, so yeah, I go to the toilet more often. What do you ask if someone said that? What would you want to find out more about? What would make you think, is this a pelvic health issue or is this a Cauda equina?
A period of time. How long has it been like that for?
Mm-hmm.
It's been like 10 years. Slightly different.
Yep.
What are they doing more than one or two? Is there adequate emptying when they do go for number one?
Mm-hmm.
But then if they have inadequate emptying, that can also be down to floor.
Yeah. And that's why it's so tricky, isn't it? Because a patient may say, I'll go to the toilet, but I don't feel like I can fully get it out. Which could be a sign of Cauda equina, or it could be actually weak pelvic floor muscles. It could be they've got a prolapse organ that's causing them to have a blockage. They can't get their urine out.
With Cauda equina, don't they lose the ability to actually even know when they need to go?
Yes.
What I would ask sometimes is, do you actually know when you need to go?
That's urgency. Same thing? Or?
Surely if it's true Cauda equina, they would completely, the signal's not going up anymore, right? So they wouldn't know when they need to go.
So it's with Cauda equina, true Cauda equina bladder dysfunction is retention. So bladder retention. So they don't have a sensation to empty their bladder, or they may find they're leaking because they haven't emptied their bladder for hours. They're overflowing.
Is distension quite common with that?
Yeah, exactly.
Okay.
Yeah, exactly that. So I've got a patient at the moment. She's got a long-standing bladder issue, and she's supposed to have self-catheterize to be able to empty her bladder, but she found it really uncomfortable. So she's constantly in a bit of retention, but she leaks. So she's leaking because she can't empty her bladder. But that's not Cauda equina. That's again a bladder dysfunction. So again, two things can exist at the same time.
And who diagnosed her bladder dysfunction?
Urology.
Urology.
Yeah.
Okay, fine. So there would be a case that could be either or.
Yeah. So when these patients present to you, it's always better. I'll come on to it anyway in a minute. Is to send these patients to ED because it's beyond your scope. It's better to be safe than sorry. It's better to send them to A&E and get it wrong and delay it, and it be a permanent, life changing event. And when they get sent to A&E, they'll do all the scans. So they do a bladder scan and see if their bladder is actually in retention. They'll do an anorectal reflex. And with the digital rectal examinations, they're not always the first kind of line of assessment, because you can have no reflex and still have no cauda equina. Not everyone has an anal reflex. Do you know what anal reflex is? Tap the bum and it should wink, basically. You should have a reflex. So with the bowel, if someone has cauda equina, again, we've got different types of cauda equina: complete, incomplete. With a complete, it'd be incontinence of bowel. So they literally, again, that's a late sign. Patients usually won't come to you saying they're just emptying their bowel unintentionally. You still ask those questions because, again, it could be actually they have IBS and they leak a little bit, which is, again, a pelvic health issue, not a cauda equina issue. So again, I think with the bladder, it's all asking about changes of their symptoms. When did it start? How often do you go to the toilet? Do you get a sensation to go to the toilet? Do you know when you're full? Are you fully emptying? Do you feel like you're fully emptying? Yeah. So again, just gone through questions. Other things that can affect your bladder: medications. So any medications you can think of that might impact the bladder in any way? More bowel. So opioids probably affect your bowel. Constipation. Any other medications? So antidepressants, they slow down things, so they can affect your bowels, make your bowels move slower, so you get constipated as a result of being on anti-inflammatories as well. Slow things down. Yes, yeah, so there are more medications that can slow things down. Anything else that can impact the bladder, do you think? Any other medications? Or anything else lifestyle-wise that can impact your bladder? Yeah. Yeah. So again, if someone says to you, okay, I'm going to the toilet more often, yeah, is there a reason for that? They've had loads of coffee this morning. They drink a lot. They drink before bedtime, so they get up in the night 10 times, go to the toilet because they had coffee just before bedtime. Again, it is going a little bit into more pelvic health scope. But again, if a patient comes in with these symptoms, you want to find out a bit more rather than saying, oh yeah, that's a sign of cauda equina, send them to A&E. Yeah.
In your mind, if you're doing like a voting system, that you're seeing, you're asking us what's the most likely culprit, and then you almost rank them. So if your suspicion of cauda equina is way low, then you wouldn't. But if it's a bit of a blurred line, you're much more likely to.
Yeah, if I'm not sure, I'm still going to send to ED and let them make the call. I'm always going to give the patient information about cauda equina, because it might be the early onset of cauda equina, and you're just covering yourself and covering the patient. But also, in my scope, I'm thinking, is it more of a pelvic health issue or is it a cauda equina issue? And again, I'll come on to it in a minute, but it's not one symptom. You won't just send patients only because they're leaking. It's a combination of symptoms, not one symptom alone. Spoke about bladder retention and urgency. And with the cauda equina, it's more about bladder retention rather than urgency, frequency. I spoke about, are you leaking without realising, which might indicate overflow. Yeah. And someone can have like a neurogenic bladder as a result of cauda equina. So if it is delayed, then the nerves of the bladder are impacted, and that means permanent catheter. So that's why it's so important that we safety net these patients and send on ASAP if we have any suspicion. Okay, so again, I mentioned about bowels and things that can cause that, and most of the population over a certain age will have some form of diverticulitis. So, impact, little bits of can't think of the word, within their colon, little kind of lesions in their colon which can affect their bowels.
Are they always fissures with diverticulitis?
Most commonly, yeah.
Okay.
Yeah. But if you look at most population, they will have some signs called diverticulitis, especially at a certain age, so over 55, maybe even younger, which can then obviously change their bowel habits. So with bowel disturbance, again, usually with cauda equina, it's going to be the constipation side of things. So if the patient starts to experience a new onset of constipation and they've got no other risk factors for constipation, again, you're thinking, is it a cauda equina? But again, it's a late sign constipation. It's not the first thing we always think about. We always think about it being incontinence, bowel incontinence. But it could be actually constipation, which is an early sign of, so a late sign of Cauda equina. Yeah.
Does it more commonly affect the bladder rather than the bowel?
Yeah.
Because whenever like I've looked it up or whenever we have these sessions, it's always a lot more focused on like the urinary side of things rather than
Yeah.
the like kind of bowel.
Yeah. When you think about the digestive system, it's an enteric system, so it's its own mini brain, isn't it? So it's slightly controlled differently to the bladder. So usually it will be bladder symptoms, but we can't always forget the bowel. And then when we're thinking about obviously the symptoms, thinking about other things that could be contributing to your symptoms that are not actually Cauda equina. And that's what we ask about in the medications, or you might not ask, and then you ask their medication history, and they are taking antidepressants recently. And okay, that could be related. Go back to your GP, mention that, then they can come back and see you in 2 weeks. Oh, it's better now. You know, it's not Cauda equina, but you've satiated them in the meantime.
Yeah.
You know,
And constipation's a hard one because so many medications cause constipation. So I guess it's like you say, maybe right at the very end. If someone's in a lot of pain as well, like those pain meds,
They're going to be
they
taking them.
literally back you right up. So you're going to probably have constipation as well.
Exactly. And that's why, it's not just a symptom alone that you're, someone says I've got constipation, not thinking Cauda equina. You're just thinking, okay, let's keep an eye on this. Is it a new constipation? Is it because of your medication that you're taking? Is it because of stress? Because of your diet? So I might make this one bigger. I'll make this bigger. So yeah, there's lots of things that can cause incontinence and constipation, from functional to medications to diet, lifestyle, neurological conditions, GI problems, psychological. Someone stressed, anxious are going to be more likely to be constipated. It could be the other way around, nervous poos. Goes to the toilet a lot, but again, it's not a sign of Cauda equina. If you're going to the toilet a lot, it's not going to the toilet. And then systemic issues as well can also cause constipation. Okay, so have you heard of, you may have, Katie, GERFT, getting it right first time? Yeah, you heard of it as well, yeah. So this has been put in place, this pathway, to help make sure patients are seen quickly at the right time, basically, getting it right first time. We fit more into the first column, because we also usually see patients after they've seen their GP, or they won't have seen their GP, they'll come straight to us, and we're the people that are responsible to send them to A&E. So with Cauda equina, it's important that you're looking at acute symptoms. So symptoms, according to the guidelines, are changed within 2 weeks. Yeah, so if patients had bilateral symptoms in their legs, a patient's had anaesthesia for years, but it's changed in the last 2 weeks. Because when you send them to A&E, if they've had long-standing ED, they're going to be like, it's been more than 2 weeks, so it's not likely Cauda equina. So you need to ensure, if you are writing a letter, you say how long it's been, within 2 weeks. So it's 14 days. And it's about change. Even if it's not been 14 weeks of symptoms, if that symptom has changed, so they're now going to the toilet more often in the last 2 weeks, unexplained. They've lost sensation in the bladder in the last 2 weeks, more than normal for that patient. So you can easily use this flowchart to help guide you, to make sure the patient gets the right treatment at the right time. And it's been really effective in primary care settings with GPs. And also it also helps with A&E. We're kind of quoting this because we're referring to them because the pathway says this. The pathway says if they had a change in symptoms in 14 days, we send on. So we're covering ourselves. Yeah. Any questions about the pathway? There are other obviously parts of the pathway, but we might see them post-op. We might see them post-op Cauda equina decompression.
I've used it before to refer to Cauda equina syndrome.
Yeah.
I have found a couple of times that it's been some of the bottle. So
from A&E?
From consultants saying that. Because I think when I've spoken, obviously I can only speak through what patients told me, that because it's they look at it more clear cut rather than possibly from the kind of syndrome completely. So if it's not clear cut, then they don't bother, which I thought was a bit weird because getting it right first time was like in doubt, just test anyway. Yeah, so that's what I found.
Yeah, so it's really difficult because we send so many patients to A&E with suspicion of Cauda equina, and some come back and they haven't had a scan. And it also depends where you go. So if you go to Medway, often won't have scans. If you go Maidstone, they're a bit more on it. When they're in A&E, obviously they'll do their own subjective exam. They may do a digital rectal examination, and they may just do a bladder, and they might just do a bladder scan, and that's it, because they're looking for all that retention. With a MRI scan, so when they look for Cauda equina, they do a really simple MRI scan. So they don't look at the rest of the spine. They're not looking at disc bulges or arthritis, other pathologies that affect the spine. Looking at is there complete compression of the spinal cord, and if there is, they usually will then liaise with King's MDT, and then if they're suspicious of that, they then get sent to King's, and it's usually you'll have surgery within a period of time. It's not always then and there, but it's definitely within days. So yeah, I think your job, as long as you've documented that you've satinated the patient in your notes, you've definitely covered yourself, and you can give out leaflets. You can give out information about Cauda equina symptoms, because sometimes you may be suspicious, but actually it could develop. They could develop very quickly, or it can develop very slowly. If someone is of a certain age, if they're in their 80s and they do present with bilateral leg symptoms, but no other symptoms, again, it could progress to that. So you're satinating the patient, yeah. So you covered yourself basically, because a delay will affect their quality of life. And again, it's not life threatening, but losing your bladder and bowel function is important. Okay, so red flags of Cauda equina syndrome. A weak pelvic floor muscles can both involve urinary, bowel, sexual dysfunction, but they also have very different causes, urgency, and implications. Yeah, so pelvic floor weakness is more of a quality of life, whereas Cauda equina is more of a serious condition that needs medical attention. It needs a spinal decompression. Yeah, that's the treatment for it, spinal decompression. Okay, so obviously I spoke about our role is to rule out Cauda equina. If you've come to be ruled out Cauda equina, it's pelvic health, likely pelvic health related. Yeah, if it's not pelvic health related, you're referring to the GP to query some neurological condition. Yeah, or you're referring to the GP to refer to urology or gastro if you think it's something else. Yeah, but again, they're not usually serious conditions. So key symptoms of mixed urinary incontinence compared to Cauda equina is patient will leak with coughing, sneezing, stress incontinence. They might have an urgent need to go to the toilet. They might not quite make it to the toilet, which is different to having a cord compression. And they won't have any numbness or weakness. That's a big important thing to say. So someone who has Cauda equina, they'll have motor weakness and sensory changes.
Does that mean that if it's more the mixed urinary incontinence, they wouldn't have reflex changes?
Exactly. So obviously with your objective examination, sometimes you won't even need to do an objective examination. They said enough in their subjective history to go to A&E. An objective examination isn't going to do anything. It isn't going to change anything, should I say. You're still going to send to A&E anyway. But if you assess a patient who's got back pain and they do leak when they cough or sneeze, they shouldn't have any neurological changes on reflexes. But again, one neurological change isn't positive of Cauda equina. Not everyone can get reflexes right. It could be technique. Yeah. It could be actually, you might say it's normal, it might be brisk. Yes, it's very subjective with clinician. But they're dragging their legs when they're walking. You can see they've got a complete foot drop. Then you think, this is more than just bladder incontinence. Generally, obviously with bladder, they won't have any bowel dysfunction. And generally, you know, when they come to see you, they're seeing you because they have pain, like when they come to see you guys. But with pelvic health, they generally won't have back pain if it's just pelvic floor weakness.
Sometimes when it's passing, I think.
Yeah.
Someone said that, I asked them to start doing squats just to get their back flexion extension, and she mentioned that she gets evidence, sagging feeling when she does so. So
Prolapse. Yeah, so that could be some topic. Pelvic organ prolapse. So one of the organs could be coming down. So yeah, could be because of weak pelvic floor, but you can have a prolapse not because your pelvic floor is weak. It could be that you just got a structural descent of an organ, even though your muscles are strong. They're just the structure, the fascia is just dropped. So yeah, that could be one you refer to pelvic health. But yeah, that wouldn't be a sign of Cauda equina. But if they were leaking with that, again, you wouldn't be thinking Cauda equina. It could be again because they're straining their pelvic floor. Their their muscles are able to control them while they're bearing down and squatting. Yeah. So I've just kind of separated these into two columns to help kind of differentiate between the two. What is a weak pelvic floor muscle and what is a more likely a Cauda equina. So the cause of the Cauda equina is nerve compression. That could be from discs, arthritis, and then also we know about red flags such as cancers, cysts. So that's why we ask those other questions to see is there an infection that's causing spinal cord compression or weakness. Onset. So onset with Cauda equina is generally it's going to be sudden, but they can have, I mentioned before, progressive. They will have some symptoms of Cauda equina that are getting worse. Yeah. And with pelvic floor muscles, generally it's over time. So they've had kids started off just jumping on a trampoline, leaking, and then over time it's become they laugh, they leak. And in men as well. So men obviously have pelvic floor, so the same thing's can happen with men. And especially if they've had prostate cancer and had prostatectomy, so prostate removed.
Is that of interest? Would you ever go and smell? Because, like, for example, I have a lot of people who come in and they're generally atrophied, and when they're getting changed, I can smell urine.
Yeah.
So that could also be a sign that the pelvic floor is just.
Yeah. So you. No. You could say just go through your history and say just check any red flags because you're here with this problem. Say do you leak with coughing, sneezing, laughing? That can open the door a little bit, and then you can say, it could be because of your age, you're more likely to get pelvic floor weakness, which makes you leak unintentionally. And if that's the case, I can show you some exercises to help that, because when you're exercising, you're leaking, and they're not exercising because they don't want to leak, so they're not getting better with their musculoskeletal problem because it makes them leak. Yeah.
With pelvic health, would the muscles get stronger just from doing general strength training, or does it have to be very specific exercises?
Yeah, it has to be more specific, because if a patient can't activate their pelvic floor with exercise, so you try to isolate the pelvic floor by teaching them just to engage their pelvic floor, which again I can go through if you want to, and then adding it into their exercise, because if they're doing a sit up and they're not able to engage, or they're bearing down and then they leak, and you're trying to get them to do more sit ups, that's going to make their abs strong, but they're still going to be leaking, so their pelvic floor's not doing what's supposed to do.
So my interpretation of it is that specific pelvic floor exercises of education and control. But if someone doesn't have, for example, or for strengthening, if they're having a functional deficit. If I have, for example, someone who comes in and they're like, I want to strengthen my pelvic floor, I don't have any bad symptoms, any weak, I want to strengthen it. That's when I'll say that you should be generally exercising, because of the balance between the diaphragm and the pelvic floor anyway. Yeah,
so generally you'll teach patients to do their pelvic floor exercise if they're symptomatic, right? Yeah. So they come in and they might mention in passing, that makes me pass wind when I do that. I can't stop that. It's not always weak. It could be actually passing wind unintentionally as well. Like when they bend down, because they can't control their pelvic floor. So, you can then address their pelvic floor. So then when they're exercising, they know how to engage it. So rather than holding your breath as you do a sit up, because that's putting intra-abdominal pressure down on your pelvic floor, and it makes you then pass wind. So you can then teach them to engage their pelvic floor, pull up, engage. You've got it engaged. Now do your sit up. Breathe out on exertion. You don't hold your breath. Yeah. With pelvic floor training, it's difficult because you're adding it in and then you're almost taking it away. So you're making people aware with it, and then you've got to try and say, okay, now don't overthink about your pelvic floor and do your exercises.
But you are asking them to hold it whilst you're doing your exercise. You might have some like that elevator.
It changes. It's patient to patient.
Yeah.
So for example, you're teaching patients to do squats and they've got weak pelvic floor, they leak when they go on the trampoline or cough, sneeze, laugh, whatever it may be. You've taught them to do the pelvic floor exercises. They need to be able to do X, Y, and Z before you move into the next stage, which should be your squats. So they can do their pelvic floor exercises, the whole contractions, and they don't feel any heavy dragging sensations when they're walking. You get, okay, now we're going to progress into squats. So I want you to do a pelvic floor squeeze as you do a squat. And then you come back up, you relax your pelvic floor. Or you might get them to do a squeeze as they're squatting the whole time and then relax your pelvic floor. Yeah, it all depends on their symptoms. So patients, most of the time, they don't always leak laying down. So you're not going to teach them exercise all laying down. You might teach them to do an exercise while they're standing or doing a sit to stand. It's like an elderly lady. Yeah. But they need to do the basics first, which is a pelvic floor activation, and be able to do at least 10 repetitions and 10-second hold 10 times according to the guidelines before you move into the next step. Yeah. Does that make sense?
Yeah.
Yeah.
You integrate and then you gradually get them to forget about it once they're
Yeah, because it should become automatic, like it is now. You're breathing. You're not telling your lungs to expand and it just happened automatically. Yeah, but when you have symptoms, you're more aware of your pelvic floor, aren't you? And when you're leaking, you're more aware that you've got to engage it. Whereas if you're not aware that it's your pelvic floor that's not supporting your bladder when you're standing, you're not going to know how to engage it. Yeah, that's like a whole nother topic in itself, pelvic floor training. So urgency. So obviously with Cauda equina, it's straight away needs immediate attention. Whereas pelvic floor weakness, it's not an emergency. They can come and see physios at any point. It's not gonna die. Yeah, but again, it's your quality of life. They might not go out the house because they don't want to leak. They're embarrassed, which then means they're deconditioned, which means they're then social isolating. So that can have other impacts. And obviously, the treatment for Cauda equina is surgery. Pelvic floor exercises for weakness.
Mesh products, is that right? It's a product.
Yeah, they use like slings now. So they used to use mesh, but they cause chronic pain. So they stopped using those years and years ago. So they literally just kind of stitch up your fascia, your own tissues now. Or you might have a pessary ring, which looks like a cock ring basically, which holds the walls up.
Looks like a what?
Cock ring. You know what that is? Yeah. So it's like a rubber silicone ring, and it comes in 1 centimetre, not 1 centimetre, up to 10 centimetres basically. That's the biggest you can get. And it basically just holds the walls up. There are other devices. There are like cubes. There's like the ring with a bit of flat material in the middle. I've got one with me now. Or I haven't. It's it looks like a tampon. It's got like wings on the end, which basically holds the walls up. Yeah. No.
Oh, people could just.
Yeah. So so most of the time, they're changed every 6 months. I'm going on to the topic now. They're changed every 6 months, usually by a nurse or someone in the GP surgery because of the risk of infection, skin breaking down. If someone has hormonal changes, they're dry in their vagina, so they're more likely to break down and have infections and pain. So,
sorry, Charmaine, so the ring and that which you mentioned is non-invasive, it's non-surgical.
Yeah.
What was the other one called again?
No, they're basically the pessary devices. Okay. Yeah, they're pessaries that help to support the bladder. But they're changed every 6 months. You can get some for women. So, say if you get a patient that comes in with distress incontinence, when they're running, they can use one that's called a Contrail, and it looks like a tampon. You wet it and it doubles in size, and it basically supports your bladder while you're running, and you take it out after 17 hours. Yeah. Some women may say actually when they wear a tampon they don't leak because it's supporting the bladder. That's another topic. It's a whole other topic. But yeah, that's if a patient was to say to you, have prolapse or they might already be under gynecology or waiting to see gynecology. So in pelvic health, there are other red flags which are not related to Cauda equina, but they're maybe things you might think about or a patient might report to you. So red flags in pelvic health. So abdominal pain is a red flag. So abdominal pain, in terms that you might want to find out the location of the pain. You want to maybe find out on examination. You might don't know if you ever palpate abdomens. Do you palpate abdomens?
Yeah, we can talk abdominal exams at uni.
Yeah.
Rarely do it.
Yeah. Yeah. Again, it's beyond our scope, isn't it? So if someone's reporting abdominal pain, you're going to go back to the GP, aren't you, anyway? Pain during intercourse in pelvic health. Again, yep.
Okay.
Yep. So it could, again, finding out, is it pain because of that infection, for example? Is it because of trauma? Is it dyspareunia, which is pain on sex? And that's usually because there are potentially some psychosocial issues. They've had some, sexual abuse. Could be traumatic delivery of baby, and that's then caused, another term is vaginismus, a spasm. It could be abdominal bloating, swelling, which again would maybe indicate something more serious, like a cancer, pancreatitis, something like that, for example. Unexplained vaginal bleeding. So if patients come in, they're 60 years old and they start to bleed, you're thinking straight away, that's not normal, and they're postmenopausal now. So again, you're going to signpost back to the GP. Again, like infections and things, or sexual infections, discharge changes, unexplained weight loss. Again, you're looking at cancers and things like that. Unexplained weight loss, again, which is 5% of body weight. Yeah, in a short period of time, 6 months. Loss of appetite. They're generally red flags in pelvic health that we ask. But again, might not be really relevant for you, but it might be things you might think about, or a patient might mention to you, and you think, actually, this is not my scope. Let me just signpost.
I guess you would be quite concerned if you had, say, a woman of menopause age that was
Yeah, exactly.
I did have a patient, I don't know if I actually told you about this lady, but she was like 55 and she had unexplained bleeding. And long story short, she was actually pregnant. And she'd already gone through the menopause. And then
Oh, wow, that's rare.
she went to hospital. She was like, really don't feel well. And like her and her husband were joking. Her husband was like, oh, you're just being so dramatic. She was like, I feel like I'm having contractions. Like, she's got like 3 grown up kids.
Wow.
And then he was like, oh, like, you're being so dramatic. She's like, it really feels like contractions.
Wow.
And then basically she went to the toilet and then she'd had a miscarriage. But she was just like in so much shock because she'd already been through menopause and she was having all this bleeding, and she was like, it was just so crazy. And she was, it just made me think that actually stuff like that does happen.
It does.
You might not think, just be like, oh, that's her age, but yeah, she was actually pregnant.
Yeah. So menopause is basically kind of diagnosed as not having a period for a year. So some patients will have like no period for 6 months and then have a period. That's like perimenopausal. And not every woman will have the typical brain fog, night sweats, lethargy, aching, all that kind of thing you hear and see about. So I think it's what is normal, and when you hit a menopausal age and you haven't had a period for a year and you're having any bleeding, abdominal pain, just send back to the GP. It's beyond our scope and it's not musculoskeletal. We're looking at musculoskeletal conditions, not anything else. We're just ruling out. We're kind of just triaging. Yeah, we're triaging. Yeah. So yeah, Cauda equina and pelvic health is closely related. I think it's just having the confidence to see and think, okay, if it's one symptom, it's unlikely. If there's a combination of symptoms, it's likely, and it's always better just to safety net the patient, always document legally. That's our obligation to make sure we've covered ourselves. And early detection is key. So if you miss it, then it could be really life changing for that patient. Yeah, if you have any pelvic health kind of patients or you want to discuss any with me, I'm happy to discuss them. But pelvic health is quite a broad broad subject, but most patients I see in my musculoskeletal clinic will have some kind of pelvic health issue as well, and they might not disclose it until I ask those red flag questions. I'm like, oh, okay, why don't you come and see us in our pelvic health service? So, like opening up a door for a patient who's probably been quite bad. It's so taboo, isn't it? Leaking, you know. Oh, I've had 2 children. It's normal. No, it's not. It's common. It's not normal.
A lot of women wear those pads, don't they? Like just for your leakage.
Yep.
A lot of women.
Yeah.
It's the same thing. Like it's always when asking that for the recliner, and then you get on to the top of it.
Yeah, pops up. Yeah, and it's closely related with pain. So when patients are in pain, so they take painkillers, that bungs them up. They might be gripping, tensing all the time. So their pelvic muscles are like this all the time. So then when they cough and sneeze, their muscles are like, I can't do it anymore. I'm knackered. You leak. Yeah. So it's really closely related. So you might treat the back pain. Actually, they're gripping all the time because they're in pain. So it's then affecting their pelvic floor. So they then come and see us, and we work on the pelvic floor in combination with you guys, like for backs or whatever it is you're treating, to help both. Yeah. That's like a little whistle stop tour to a bit of pelvic health, and obviously the red flags. I think we ask questions, but sometimes we don't know why we ask the questions we're asking. We just read off the list, maybe more junior staff, but just read off the list of, do you have sad anesthesia? Do you have bilateral leg pain? You know, but asking a bit more, you know, do you have bladder symptoms? Yeah. Or they usually say no. But if you ask more questions, or you say, give examples, oh yeah, actually, yeah, exactly, and be comfortable asking those awkward questions. But like, you know, morning stiffness. People are not saying, do you have any morning stiffness? You know, that's, you know, but could be a SBA, you know, spondyloarthropathy that's causing, you know. So ask those questions. Ask a bit more.
So you ain't
Yeah. So thank you.
Thank you.
Yeah.
Yeah.
Thank you, Val. Thank you, Val.
Yeah. Sorry, it was very rushed. Sorry.
Yeah.